Hi, my name is Connie and you're watching the video on the management of convergence excess accommodative esotropias. Let's start off with the convergence excess accommodative ET that is related to a high ACA ratio. Now with these patients, if they're hypermetropic, then you should fully correct the hypermetropia. The other thing you can do is prescribe bifocals. And in prescribing bifocals, what you're doing is you're reducing the amount of accommodation that the individual needs to do when they're doing close-up work. And given that they have a high ACA ratio, these children will respond well to bifocals, as with a reduction of accommodation, they'll have quite a bit of reduction in accommodative convergence, which will lead to BSV through the bifocal segment. Now, you should only give the bifocals if the individual can achieve BSV through the bifocal segment. You should never give it if the deviation is still manifest through the bifocal. In terms of what add to prescribe the patient, you would prescribe the least amount of add or the least amount of plus that gives the patient BSV. Now, let's have a look at the image here to the right. Here we can see the child is looking into the distance and we can see that they have straight eyes. And then we're looking through the top part of the glasses and we can see that the patient has a left esotropia at near. So here we have that convergence excess accommodative ET where the patient has straight eyes in the distance and an esotropia at near. However, when they look through the bifocal segment, the patient becomes straight. So this additional add here allows the relaxation of accommodation and accommodative convergence, and the patient is now straight. Now what you'll notice is what's prescribed is a executive bifocal, which should bisect the pupil and takes up half of the lens. This is particularly important in young children. You don't want to give them a small bifocal section. You want the add in the entire bottom section. Another thing to point out is that when you have a patient who has an esotropia at near that is controlled with bifocals, this is confirmation that you have a convergence excess accommodative ET. We'll see later that there are non-accommodative convergence excess ETs, or we have patients with partially accommodative esotropias who have a convergence excess pattern. Now, these patients will not straighten up and have BSV with bifocals. The only patients who will have straight eyes with a bifocal segment is the patient who can be classified as the convergence excess accommodative ET. Now, there is some controversy around the long-term use of bifocals, and one of the concerns is that with bifocals, what you're asking the patient to do is consistently hypo-accommodate at near. So these children are being asked to do less accommodation through the bifocal in order to gain BSV. And this could lead to other issues later down the track with the hypo-accommodation. So some clinicians prefer to manage these patients surgically rather than utilising bifocals as a long-term solution to managing the deviation. If bifocals are being used as a long-term treatment, then as the patient is older, if they want to discontinue bifocals, another option is utilisation of monovision contact lenses. So with monovision contact lenses, what we'll have is one eye will be used in the distance, so you'll be giving them the hypermetropic correction for that, and the other eye will be used at near, so you'll give them a bit more plus there to relax accommodation at near. Patients have been found to do quite well or tolerate this treatment quite well, but it will be dependent on whether the patient is comfortable with that monovision. Okay. Moving on to occlusion, you will prescribe occlusion if amblyopia is present. As I mentioned previously, some of these children who are hypermetropic may have had a constant deviation without their hypermetropic correction, which can lead to amblyopia. However, obviously with the glasses on, we now have an intermittent deviation, so this should be protective against further development of amblyopia. However, you may need to patch to improve the visual acuity in the first instance. In terms of orthoptics, not all patients are suitable for orthoptics if they have a convergence excess accommodative ET, and particularly those with larger angle deviations, so those with greater than 20 diopter ETs, and with a very high ACA ratio of more than 8:1, and that's often the case. If you are to provide exercises to these patients, we're wanting to exercise negative relative fusional divergences, so stereograms, for example, in the stare-through position, or fusional divergence, so base-in prisms. Okay, another option we have is myotics. Myotics are only used in terms of strabismus in convergence excess accommodative ET. And what it does is it peripherally stimulates accommodation so that we don't have the excessive amount of accommodative convergence that goes with accommodation. So with that myotic, what we have is a reduction in the size of the deviation at near when there is a demand for more accommodation. Now, you don't use this as a long-term treatment option, and generally you should discontinue it within the first month if there is no improvement. If there is improvement after the first month, then continue for 2 to 3 months, and then you wean the patient off the myotics. It has been shown that repeated use of myotics over several months can help an individual maintain BSV for more of the time. However, it's still thought that bifocals are more effective than myotics, and it's worth noting that myotics are not commonly prescribed in these patients. In terms of surgical intervention, the surgery of choice is the bimedial rectus recession. So here we're targeting the 2 medial recti in order to have more of an effect at near, and we'll actually target that near angle deviation. Now, there is some evidence to suggest that you could operate on the prism adapted angle, but not all surgeons utilise this method to determine the size of the deviation that they will operate on. Another consideration is that some surgeons also do a Farden. A Farden is also called a posterior fixation suture, which is, just as that term suggests, a suture is added posteriorly to the extraocular muscle. And what you're essentially trying to do is change the effective insertion point of that muscle. What the Farden does is it has no impact on the deviation in primary position, but it has an impact on the deviation in the direction of action of that extraocular muscle. So as the patient moves their eye in the direction where that extraocular muscle is used, you see the effect of the weakening of that extraocular muscle. So in this instance, with a Farden of the medial recti, what you'll see is a reduction in the esotropia at near as the medial recti being used at near. Now, in this instance, it's combined with a recession of the extraocular muscle. So the surgeons will recess the extraocular muscle and add a posterior fixation suture. The idea of using the posterior fixation suture is to try and avoid an overcorrection of the deviation at far. Remember, the patient is straight at far or may have an esophoria. So some of these patients may be at risk of developing an exotropia at far when you operate on the maximum angle at near. It's suggested that a prism adaptation may assist in determining those patients who are at risk of developing an exo in the distance. And what you'll see with the PAT is that the patient will have an exotropia in the distance. Alternatively, the patients who would do well, according to the PAT, are those who end up with an esophoria, both near and far, with the adaptation. And finally, let's discuss hypoaccommodative convergence excess esotropia. The treatment of choice here is glasses. Where you have hypermetropia, fully correct this, and if at all possible, this is one of the very few instances we would consider overcorrecting the hypermetropia. But you have to be very careful with this. You do not really want to do this at the expense of visual acuity. You are permitted to lose a few letters and up to a line of visual acuity, but anything more than that is too much of a compromise for the overcorrection of plus. If the hypermetropia correction is not sufficient, then add a bifocal. And bifocals are effective in these patients as it provides the patient with clear vision at near without the need to exert that excessive accommodation that they were otherwise doing because they had this hypoaccommodative issue. Again, only prescribe the bifocal if the patient can achieve BSV through the bifocal segment. If you want to confirm that the patient does have BSV through the bifocal segment, you can perform tests like Baggellini striated glasses, where they should have a cross, and then tests like random dot stereo acuity, so a Lang or a TNO. These patients should be able to pass stereo acuity tests or random dot stereo acuity tests and give you a BSV response for tests such as Baggellini striated glasses. Okay, that brings us to the conclusion of this video. Thank you for watching.